All right, 6:03. I think we'll get started here. So, welcome to the Rochester Academy of Medicine. I guess I should stand on the microphone. My name's Lee Wei Chen. I'm a cardiologist at the University of Rochester, board member here at the Academy since 2014, and past president of the Academy, and currently chairing the CE committee. And this is a program that we have had a lot of fun putting together, and really pleased to have a great turnout for this event. I'm going to introduce each speaker, who will give about a 15-minute presentation. We'll hold questions for the panel at the end. I'll introduce the second speaker, third speaker, fourth speaker, and then we'll do the panel. This is a topic that we've thought about for a while that we wanted to host here at the Academy. The impetus is that I think we all are somehow touched by artificial intelligence, whatever you define it, some way or another. I was commenting that just driving over here from work, I used Siri to do some dictating of some text messages. I had just signed off on a Microsoft DAX Copilot written note in my electronic medical record, and I jokingly said I probably passed a red light camera, and hopefully it didn't record me and send anything back to the cloud. But it's the world we live in, and I think there's a lot of information out there, and we wanted to host tonight to just get something started, particularly for the Rochester area, the Rochester community. On February 4th, we're hosting another similar event with the same panelists, but we're going to have a little more medically directed continuing education event for that time with CME credits. All right, I'll get started. We're very lucky to have these four speakers, and I actually had to beg and plead for them to join us and give their time and come out on our Friday night, probably with football games or other things to watch for playoffs, but appreciate that they're here. The first speaker is Dwight Rahm. He is the Executive Vice President and Chief Digital Information Officer for Rochester Regional Health. He has been there since December 2023. He had a very long career at Johns Hopkins, and I think over two decades, including serving as Chief Technology Officer at Johns Hopkins. We're very lucky to have him in our community here in Rochester and here tonight. And we're having him start off with an introduction about artificial intelligence. Dwight.
Good evening, everybody. Thank you very much for having me here. This is actually kind of a realized dream for me in a lot of ways. The opportunity to talk about technology in healthcare. I've spent, as Lee Wei said, about 25 years plus in healthcare, and all of that leading technology. And for me, it's an exciting time because I finally get to see the fruits of all the investment, all the labor that we put into building the foundations of technology start to materialize in a really meaningful way that can transform not only patients' lives, but also providers and advanced practice providers, how they deliver medicine and using technology, not as an evil tool to have to manage with and deal with all the time, but really embrace and use the technology to change the way they deliver that care and really empower them. So I'm going to spend the next 10 to 15 minutes talking really briefly about AI at a kind of a primer level so that we have kind of a tee up for our ensuing speakers here. So I'm going to start off a little bit with the reality of where we are in healthcare in the U.S. And it's kind of a bad news story in a lot of ways. So when we look at this graph here, which is from the Organization of Economic and Collaborative Development, this is just really great data about how much spending organized and developed countries spend on healthcare versus per capita GDP. And you'll notice that there's a really giant outlier here. We've got the United States as that little green circle, and we spend the most of any developed country on healthcare per capita. And you'd think that for that spend that we would have exceptional care. And it couldn't be further from the truth. By most measures, and probably one of the most meaningful measures, life expectancy, we actually are well below the mean when it comes to the actual outcomes that we have for that spend that we spend on healthcare. And the reasons for that are really complex, and I'm not a healthcare economist. I can't really get into all the details behind it, but I'll touch on a few. We have a large uninsured population, so patients aren't seeing their providers or seeking care until it's too late in their journey. So oftentimes, the ED is their primary location of seeing a provider to receive care. We've got some really antiquated models for how we reimburse for care. Much of the country is based on a fee-for-service model right now, where we are, as providers of care, compensated for the number of patients that we see and the frequency that we see them, not really their health outcomes. So there's a misalignment of incentives there. We also have an incredibly complex regulatory environment. Because we have a split provider and payer system and government oversight, and by the way, the government is the largest payer in the country, tremendous amount of regulatory compliance that goes on. These all drive costs. Also, we have a very complex tort system in the US. We also, we look at some other drivers here, the cost of pharmaceuticals, the development of drugs. We pay more, again, in the world for drugs than any other country. We also have an undersupply of providers. I'll get to that a bit more in a minute, but bottom line, we don't have enough people to provide the care. And then finally, we have just sort of an epidemic of unmanaged diseases. When you look at the amount of money that's spent in healthcare, it's almost 20% of GDP, somewhere around 18%. It's increasing. It will likely hit over 20% over the next couple of years. Of that almost $5 trillion, 90% of it is comprised of people who have chronic diseases that aren't being well managed. So if we could just better manage patients, instead of treating them based on an episode of care or an encounter of care, treat them on actual health outcomes, we could improve that cost curve. So this is a chart, which again, this is more bad news, unfortunately, I think. When we look at the population and the demographics of the US over the next 10 years, we see this steady increase in 65 and older. Not really a problem with 65 and older, but that population tends to consume healthcare at a higher rate. The issue is that bottom line, that red line there, that's actually the percentage of our population that actually participate in delivery of care, our healthcare workers. And you can see that they're separating pretty rapidly. The downside of that is that we have this increasing demand of care and just not enough supply of people to do it. So quite frankly, there just aren't enough Americans, there aren't enough people in this country to provide care to the population that we have. So the key thesis here, and why I'm so excited about healthcare and technology, is that to cover that gap, we really have to lean into technology. That's the only way we're going to get capacity back into the system to treat and care for our patients. And if you take that one step further, artificial intelligence is one of those key tools that will unlock that capability for us to cover that gap. So let me talk a little bit about what artificial intelligence is. First, I'll talk about humans. I think the modern human came and evolved to be about 300,000 years ago. We have, and this is kind of an average number, this is hard data to get because they actually count neurons in a person's brain. About 86 billion neurons, and then about 100 to 150 billion, or excuse me, 100 to 150 trillion synapses. These are the connections between the neurons. So that's an incredibly complex system that's evolved over millennia. And I would suggest that there's some really unique attributes to the human brain. We're mostly self-aware. I've certainly met some people that aren't self-aware, but most of us are pretty self-aware. We have this ability to have emergent learning, whether that's emotional, social, or experiential. And we can do so with just very limited inputs. If you think about how we learn and interact just from a social dimension, just a couple of interactions can inform how we behave in our entire lives going forward. We also have this incredible capacity to generalize. So when we can see a pattern, we can project that pattern in a lot of different ways and in very abstract contexts. And we can also learn incredibly quickly. We have this elasticity in our brains that allows us to reprogram and rewire pretty quickly. Now let's contrast that a little bit to AI. So AI was really conceived of, I would say officially the birth date is somewhere around the 1950s. Alan Turing, who I'm sure many of you are aware of, really conceived this idea of the Turing machine, a thinking machine, if you will. And at that time, I would say between the 50s and well into the mid 90s or so, a lot of the AI technologies that we developed were what we call symbolic AI. Okay, so this is technology that is very much like the prescriptive rules-based approach to thinking. So if then or else kind of thinking. Pretty rigid in terms of its ability to adapt, very programmatic, so it cannot really very effectively learn. And then over the last 20 years or so, two key revolutions have occurred in computer science. The first is that we just now have this massive onslaught of compute that we can bring to bear. The second is we have this massive set of data that we can start to actually use to generate and develop our models. And that is where the evolution of the general purpose transformer came to be. So the GPT model, I'm sure you've all heard of OpenAI. It's a leading AI company out there. They developed this GPT model. It really came out of a seminal paper that was released by Google in 2017. The key insight there was that they came up with a model that allowed you to parallelize the learning of these models. And why that was so important is because about the same time, GPUs started to really ramp up. So a GPU is a graphics processing unit. There's a company called NVIDIA that makes these GPUs, and they can process data in very rapid parallel fashion. Why this is important is because models shifted from being symbolic to really statistically driven in the late 90s, and then we finally had the compute and the data to actually start to build these models. So an AI model, a modern AI model, lots of different variations on it. I'm certainly not an expert, but they're essentially very complex representations of a statistical model that's learned by looking at a data set. And the relationships between the data and the parameters that are in those data actually inform how they process and come up with an answer. So models are measured in their capacity based on the number of parameters they have. So for instance, GPT-5, which was just released over the last several months, is the latest OpenAI model. It was trained on the internet, so not just like one piece. It was trained on the entire internet. It has over, well, they won't release publicly what the dimensions are, but we think it's somewhere between 400 and 600 billion parameters in that model. Now, these models aren't self-aware. They may look like they're self-aware, but they mimic really well. They do a great job of synthesizing human speech and interpreting it. They have static weighting. So, once this model's been created, they're not very dynamic in their ability to update the model. In fact, retraining this model costs somewhere around $500 million a cycle. So it's tremendously expensive to train these models. And, I mentioned we trained it on the internet. Well, we've kind of run out of data from a training standpoint for the general internet. So there is this huge effort to try and find sources of data that are rich and high fidelity that can be used to inform those models. So the other key point I would want to make here on these GPT models, but also machine learning models in general, is they're really great at consuming vast volumes of data. I mentioned that we use that to train the data, but this is one area where uniquely AI tools are actually more intelligent than humans. So we can assemble data in a longitudinal, over time perspective that humans can't really process. We just don't have the capacity to process that. But these machine learning models and GPT models certainly do. Okay, so moving on, I want to talk a little bit about the three sort of broad levels of AI models that we look at. So the first is what we call artificial narrow intelligence. And these are models that are trained generally to solve a specific problem. And they're done so using really two methodologies, supervised training and unsupervised training. So think of supervised training as something where you're running a statistical model against this data set, but you have the answer key, all right? And you're running the model to actually validate what it looks like against that answer key. In unsupervised learning, you're essentially learning from the data set that you have, and you will have emergent patterns that you can use to inform your model. But these narrow artificial intelligence models really require context. So you have to point them at a problem and give them sort of parameters and guardrails to work within to make sense. Now, Li Wei mentioned earlier that he had used Siri on his way over here. That's a good example of a narrow artificial intelligence model. Lots of others out there. I mean, certainly if you use Google, similar types of technologies. But even the GPT models that are out there right now are really still considered narrow AI tools. The second category is what we would call artificial general intelligence. And I like to think of this as like Einstein, right? This is an AI model that is the equivalent of human thinking. So the ability to think in a very abstract sense, truly have understanding, not just running a probability matrix to figure out what comes next. And then having really the understanding of what context can be. So the ability to be fluid about where that context may apply to the problem that you're trying to solve. Again, a lot of patterns like humans, the ability to rapid cycle learn, and then also to have that sort of abstract concept of what's going on. And then the goal ultimately is to get to something that's called artificial superintelligence. Again, this is theoretical, doesn't really exist yet, and it may not, as far as we can tell at this point, but it is really the goal. And that is to build an AI tool that is as smart as a human or smarter than a human. And think about all that we can do in terms of intuiting and understanding patterns, thinking, but then scale that up to a level that humans individually cannot achieve. Now, there's a lot of hype out there right now about AI. And if you listened to Silicon Valley and a lot of the billionaires that are out there hyping these technologies, they would lead you to believe that artificial superintelligence is just around the corner. It's not. All right, it's still some years off. And realistically, we're still very much to the left of this curve. We are still in that artificial narrow intelligence curve at this time. Okay, just was also further classify this. This is some language that we use when we talk about AI specifically. We talk about assistants, so Siri is a great example of an assistant. We talk about agents, so agents are purpose-built tools that are focused towards specific problems. They're trained towards that goal. Good example of that would be like talking to a customer service bot, as you call maybe your insurance company or something like that. And then we're evolving into agentic AI tools. And think of it, this is like an ecosystem of tools that are being used to solve a problem. And there may be multiple agents in that agentic flow that is given a task to, essentially an entire problem to solve. And they'll spin up different agents to solve different parts of that problem. Again, this is just kind of coming into existence now as these models have gotten much better. All right, so how can these models help healthcare? And I think our speakers coming after me will go a whole lot deeper. But for providers, for your doctors, tremendous opportunity to improve their quality of life. The biggest thing is in healthcare, we have tremendous administrative burden. In fact, 30% of that $5 trillion I mentioned earlier, we think somewhere around 30% of that is wasted time and administrative cost. Huge opportunity to take out some of those things through automation and using smart agents to address things for us. Physicians spend a lot of time documenting in the systems, the electronic medical records that we have, something like 30 to 50% of time there. To the extent we can bring tools to bear, like EMR optimization or ambient digital scribes, we can actually reduce the amount of time that doctor has to spend after hours committing to that note, then also finalizing the documentation of that note. That's a huge time savings, and it brings back the joy of medicine to that provider, and also frees them up to spend more time with the patient, having a conversation versus sitting in front of a computer, actually entering it in. And I know Dr. DeKendry will be talking about that a bit more later on. There is also a tremendous opportunity to improve the interoperability of data between payers and providers. So because of our complex reimbursement system, we have this constant exchange of data. In fact, there's this sort of theory going on that there are a bunch of bots at war with each other in healthcare, where we've got providers submitting claims and payers finding ways to challenge those claims and denying them, and then we have bots that write appeal letters and whatnot. So there's a lot going on that in terms of healthcare where we can improve provider experience and take really wasted cycles out of that back and forth. How can AI help patients? So I think all of us tend to be patients, and I think have had to engage with technologies or with healthcare that has been less than optimal. A lot of opportunities to improve access to self-service when it comes to accessing schedules and self-scheduling. Then also helping you to understand what your benefits may be, or for that matter, educating you on the disease that you may have and how you may intervene with that. There also is great promise in using machine learning and AI to develop earlier diagnosis. So for instance, if you have got a CT scan, finding a lung nodule, there are computer vision algorithms that can find those with great efficiency. In a lot of cases, they're assisting the radiologist in finding that diagnosis. That will eventually lead to new treatments and earlier treatments. So a lot of tremendous opportunity in early diagnosis, but then also treatment of patients. And then finally, there's a lot of opportunity also in risk stratification. As I mentioned earlier, that 90% of the $5 trillion was unmanaged chronic diseases. Well, if we can understand who in that population has the highest risk, we can direct resources more appropriately towards those that are higher risk and improve the overall health of the population. So how can AI help communities? Well, we just came out of a pandemic. AI was certainly used aggressively during that pandemic. I know while I was at Johns Hopkins, we used an AI model to actually do deterioration and understand which patients needed to go on a ventilator or not. That was a machine learning model. We have to leverage these tools across the entirety of the population to understand where the hotspots might be, what might be the interventions that we want to have. There's also an opportunity for us to look at the system more like an air traffic control system. How can we route patients to the most appropriate place of care based on the presentation that they have? Ultimately, our goal here is to get to reclaiming capacity for the system and narrowing that gap that I showed you earlier. So I want to kind of wrap up here at the end and give you a little bit of a reality check. I think it's pretty clear that I'm an AI optimist. I think there's a tremendous amount of opportunity here. But the reality is that there's a lot of hype out there right now. And despite the hype, there is real value and real opportunity in the AI tools that are out there. In fact, the tools that we're getting from vendors, I describe it as a tsunami of tools coming at us. One of our key vendors is providing up to 200 new AI models over the next 24 months. That's just a huge onslaught of change to bring into the system. Non-trivial to adapt that into how medicine is being practiced, a lot of complexity in the technology to actually bring it into the system. And healthcare is not exactly known for being tech forward. In fact, when you look at what we spend in healthcare on as a percent of revenue on technology, we're around 4 to 5% as an industry. Compare that to financial services, they're like 12 to 15%. So we've had a long story of not investing at the same levels of a lot of other industries. The impact of that is it takes us a lot longer to ingest new technologies and deploy them. And then the other point I want to make here is that in that hype, there's some stat that just came out over the last couple of weeks from MIT about 95% of AI initiatives in healthcare have not returned the results that they were expected to return. So there is a lot of complexity that goes into deploying these tools. So I've already kind of deflated the balloon of irrational exuberance. The foundations of technology still really matter here. We cannot just paste over these issues and fill in the gaps with AI. Fundamental things like data governance and good systems management, that all really still matters. And there's also this real risk of what we call the rise of AI slop. I talked earlier about the bots fighting each other. Well, if you've run a Google search recently, you've certainly come across AI slop. The results that you're getting are poorer and poorer day by day. And that's because there are so many agents out there, so many AI bots out there developing content which is just basically slop, right? It's totally not valuable anymore. There's that same sort of risk happening in healthcare, and we have to be very careful about how we deploy the systems to ensure that they're governed in a way and we're monitoring them in a way that does not happen. And then finally, the regulatory outlook for us is really murky. There are international, federal, and state level initiatives, as well as governing bodies like the AMA and different professional organizations that all have a stake in saying how we should use AI. But again, I'm an optimist, so I think there's a tremendous amount of opportunity here. And these are the three areas where I think we're going to see a lot of uptake in the next 18 to 24 months. A lot of back office optimization, so that provider to payer negotiation, I think we will see huge cost reductions in use of those tools. Ubiquity of ambient technologies. Greg again is going to talk about ambient in a few moments. I think that's going to become ubiquitous. We'll see the use of ambient listening tools, the integration of smart watches and data from quantified self-informing models. It'll move beyond just smart devices into patients' homes as well. And that ability to integrate those data and apply models to inform individualized care for that patient, that is happening now. And we will ultimately have what I think is predictive, personalized, and precise care of patients. So the future, and this probably won't happen in the next 2 years, but the future looks a lot like you having a digital twin, essentially your own personal bot, monitoring your medical record, understanding who you are, and making predictions about what issues you may have forthcoming, what issues you already have, and how to best manage those. So the future is bright in a lot of ways. Some of the hype is real, some of the hype is overhyped. And I think it's a really amazing time to be in healthcare, to have this critical mass of opportunities to really transform the way we deliver medicine. Thank you very much.
I think Dwight gave you some things to ponder. Our next speaker is Dr. Greg Nicandri. He obtained his MD from Virginia Commonwealth and orthopedic training at the University of Washington, where I did my cardiology fellowship. And sorry about that. The speaker does need to be, I think Dwight's louder. And he did a fellowship at Duke. His current role at the University of Rochester, besides being a professor of orthopedics, is he is our Chief Medical Information Officer and really leading a lot of our digital transformation at the University of Rochester. So I want him to come and tell you about a little bit about what is happening with us there. As you can tell, this is a very diverse group of people from different parts of our healthcare community. But thank you. Come on up.
Thanks, Li Wei. And Dwight, that was awesome. It was really good, broad kind of overview of AI. And so my job is to kind of double click in a little bit to help you all see how we're applying some of those principles to real life situations that our patients and providers are being encountered with within the health system. I was really excited to have the opportunity to come talk to you all because a lot of my day is spent talking to healthcare executives and other physicians, and I get certain types of feedback from those groups, but there's not always a lot of opportunity for me to talk to my community. I grew up here in Webster. I came back to practice here because I absolutely love Rochester. My family is all patients here of both systems. And our goal is really to make all of this work for everybody who lives in our community. And hearing your voice is obviously a big part of that. So I'm really looking forward to the Q&A panel portion of this. So kind of three things that I'm trying to cover in my portion of the talk is really how are we specifically applying some of those principles Dwight went over in thinking about AI. And then I'm going to really dive into one particular AI use case. We are using lots of AI at the University of Rochester and have been for 10 plus years. We have algorithms running on the CT scans that are ordered in our ED that identify patients who are highly likely to have a stroke and actually put it at the top of the radiologist's list so that they can read those first, because seconds really matter in those stroke situations where you need to, give TPA or a clot-busting medication quickly, and you can restore function to that patient for the rest of their life. We're using algorithms to predict sepsis at a time where, every hour matters, and we're identifying patients 4, 5, 6 hours before we previously were identifying them and giving antibiotics, which saves lives. And then we're using it for a lot of different back office tasks and for some of the ambient AI tools that I'll go into. And then, as Dwight said, there's a lot of things to consider. Is AI really this great panacea? It can be really helpful, but like any tool, it's a technology tool, and it can have negative downstream consequences as well. And so there's things we need to consider there. So this is a little bit of what the tsunami of AI looks like. Epic is our electronic health record vendor, and this was their roadmap of AI tools that they're just going to make available to all of the folks who use the electronic health record, upcoming in the next year. And this list has only got longer. It gets longer by the month. We've got publicly available tools, which are available to our providers, our nurses, our administrators. And obviously, it's extremely important that those folks use those tools in a safe manner. And so we've had to do a lot of work kind of educating folks about what is appropriate, what's not appropriate to put into these publicly available tools. We've had to kind of classify our data as low risk, medium risk, high risk. We've had to educate our entire population about what that stuff means and which type of tool you can put which type of data into. And then this is just healthcare specific products for one use case. So this is 80 plus companies that are marketing ambient documentation tools. And I think I've gotten an email once a week for the last year from every one of these 80 companies trying to pitch and sell their product as the next latest, greatest thing. So we have to have infrastructure and ability to evaluate which of these are going to be the best ones to employ within our organization for the benefit of our patients and providers. And then, we're an academic institution. We do quite a bit of research and development on our own. And so when we see problems, one of the great things about working here and being a part of this community is it's a community of problem solvers. People really like challenges and like trying to come up with their own ways of solving them. And so how do we do that in a safe, ethical manner? So we've partnered with another company called Qualified Health that really helps us kind of put the process around some of these internally developed tools, as well as provide some of the infrastructure and oversight to kind of monitor our models and make sure that they're being applied equitably and that they're not changing over time and becoming AI slop, and that they're being used appropriately. We have large governance at the U of R, starting at the university. And so a lot of these, who sets the ground rules, there's different groups in research, clinical education, administrative, and then even marketing and communication. And I sit mostly in the clinical arena. And so I'm going to dive into specific problem that we had. Dwight, really alluded to it. But this really came real for me when I went back to my 20-year medical school reunion in 2023. So before we came back to the Virginia Commonwealth University, they sent us a little questionnaire and they asked us about current and future practice plans. And in that, 25% of my graduating class, 1/4, had already left medicine and stopped practicing. 35% said that they were looking to retire early within the next 5 years. And 50% said they wanted to decrease their direct patient care time within the next year. And so, why is that? Well, this is a picture of what a clinician does. This is a real clinician in our system. On the bottom, you can see their schedule, and they start seeing patients at about 7:30 in the morning. Then they have a fully booked schedule until about noon. They take some time for lunch, and then they work until about 3:30, 4 o'clock, and that's when they're done with their scheduled patients. Up above is what they're actually doing in our electronic health record. And so what you can see is that this doctor, the purple is time in documentation, and then the blue is time in their in-basket answering patient messages. Pink is reviewing the chart, and then green is orders. But focusing on the purple, that's kind of the dominant thing. Dwight said 30 to 50%, this kind of validates that. But that person is basically doing that until their last scheduled hour. Then they're staying an hour after their clinic ended, or an hour and a half, going home, maybe eating dinner with their family, and then they're back in the chart for another 3 hours at night. And, you know, I'm a surgeon. I get to operate twice a week. But for some of my clinical colleagues, this is 5 days a week. And so, you know, where is the time in there to go to your kid's soccer game? Where's the time in there to read a book or watch a TV show? This is what burnout looks like. And the biggest contributor to that is documentation. And so for us, we really wanted to kind of tackle that particular problem. Also, this was kind of what your office visit looked like, probably from 2007 to 2023, right? We put the computer in the room between the patient, and we always, for whatever reason, positioned it in the corner of the room so the doctor could just be facing the computer instead of you, the patient. And so you get this situation where, you know, the doctor's pointing and clicking and typing information into the computer, while the patient with a scowl on their face is just kind of looking at the back of the head. And so this is not the experience that we want folks to have. And so that's where this opportunity for ambient documentation kind of came up. You know, we've always been looking for how can we get the computer out of the room. Well, here you can replace the computer with your cell phone. And I think a lot of folks have probably experienced this. Who has been involved in a visit where their doctor used ambient documentation? Raise your hands. That's great. So probably about 40% of people just raised their hands. And if I asked that 2 months ago, it was like 20%. So this is something that is being seen more and more. And if you haven't seen it, you probably will start to see it more. But essentially, the doctor, you know, usually the way I present it to my patients is to say, hey, are you okay if I use AI to help me generate my notes so that we can just talk face to face here today? And most patients say, sure, that's great. We just put the phone down, and then I just have a face-to-face conversation with my patient. And I've noticed it's changed a couple of things about the visit. So, you know, clinicians are notorious for interrupting their patient. I think it's about 3 seconds into the visit. And that's because your electronic medical record needs you to click a specific button before you can move to the next button. And you just want the patient to answer the one question you need to click. Whereas with ambient documentation, you just let the conversation naturally flow. And so you're actually able to really listen to the patient, and you're not having to worry about writing, clicking, or doing anything else, because you know it's all going to be there later for you to be able to reference. So at U of R, we've got 1,000 folks who have signed on to use it. About 806 of our providers are using it actively for about 75% of their notes. This is just showing every quarter we survey all of the users to find out you know, how it's going. So we've done 383,000 encounters. Doctors are reporting it saves them probably about 7 minutes per visit. That's 7 minutes they can give back to having a conversation with the patient, communicating, empathizing, educating. They're saying that, you know, they can see probably an extra patient a day, which with a shortage of doctors and nurses, that's great. 93% say if we took it away, that they'd be showing up at my door very, very, very upset. They feel that it's patient focused and that it improves patient experience. It improves clinician satisfaction. They feel that it improves quality, and they even say, you know, they're more likely to stay with their current organization because we've made this technology available to them. And, you know, even a couple of my partners have come up to me validating this 59%, saying I was going to retire next year, but I think I'm going to stick it out another 5 years because I'm really starting to enjoy my job again. And that is tremendous. This is just some of the verbal feedback. And this, you know, really makes me feel good. You know, when you read the highlighted things and really all of this, it's not about this helps me go home early. This helps me see more patients. This lets me take better care of my patients. I am able to talk to them, and I don't have to remember what was discussed in the visit. I feel like I am a better doctor because this burden of having to remember everything they said and write it all down at some time 2, 3, 4 hours or 2, 3, 4 days later is now lifted off of my shoulders. Patients also have been feeding back. So on the question, we send out Press Ganey questions to all of our patients. And folks who saw providers that used DAX were more likely to rate their experience as very high quality and their providers as very focused when their providers used DAX compared to the providers that did not use the ambient documentation technology. And we try to improve these numbers all the time. These numbers are very important to us as an organization. It's really hard to improve things by 1% because generally they're pretty high in around like the 90s. So 5% improvement on my doctor was very focused is just something that really we haven't seen before with other things that we've tried to deploy. But you've always got to have some balancing measures when you're evaluating a new technology. So yes, we question and query the patients about their experience, but what about no quality? The doctors said they felt that the notes were quality, but are we actually sure? And so what we do is both have kind of an internal audit where we'll look at a certain portion of the notes and review them for accuracy, but the other way to do this with kind of the big data is just to say, all right, there's a couple of reasons that our notes get asked to be revised. One is that somebody from billing and compliance reviewed the note and said, "Doc, this doesn't look like it's correct. Can you please fix it?" And the other is the patient sends us a MyChart message and says, "Doc, you wrote about my left hip and the visit was about the right shoulder. This is a problem." And so you go in and fix it. And that's been a problem forever before ambient documentation. So our note correction rate pre-ambient documentation was around 3%, and now with ambient documentation, it is around 1%. Dwight talked a little bit about agentic AI and agents, and this is where things are starting to head. And it's going to require another level of oversight because with generating a note, if I'm a shoulder surgeon and I see somebody for their right shoulder, but they start talking about their left shoulder, sometimes the note will get confused and attribute the whole visit to the left shoulder. And when I read the note, it looks very convincing, and unless I remember that specific thing, it's not like there's punctuation errors or misspellings, it's just, it reads correctly, I have to actually remember the visit to correct that. If somehow that misses my double check and you have an agent that is filling out a surgical consent form for you and the booking sheet and is automating a bunch of downstream tasks, you all of a sudden can have a really bad thing like a wrong site surgery because instead of having all these Swiss cheese double checks, you just kind of automated the whole process. And so we, when we're looking at these technologies, are really thinking about, okay, how do we put more slices of Swiss cheese into this to protect it in the age of AI so that we can prevent these bad things from happening, understanding that there is this risk. And so before we automate, before we make a complete agent, we're really trying to figure out, okay, what is the downside of this and how are we going to keep this safe? And then lastly, around education, I laugh at this. This is from The Office, automation bias. You get used to following your GPS and you just kind of trust that it's going to be correct because it's correct 99% of the time. And here it drove them into a pond, which, in that case, probably not so bad. But when you're talking about healthcare, that is a big deal. And so 99% of the time correct may not be good enough, but how do you train a new group of providers that they really have to kind of look for this bias within the AI to identify it, to prevent them from making a really, really terrible mistake? And so that's another big piece of what we're doing, and why, some people sometimes ask, well, why aren't you just rolling all this stuff out really quickly? Everybody says it's going to be great. Well, you've got to prepare the organization to roll it out safely and effectively. So hopefully that gives you all a little bit of background of kind of where we're at, and I think the next speakers are going to start talking about where we're going.
Yeah, we're going to have the panel at the end, and then, yeah, but kind of save your questions, but remember them. No, actually, what Dr. Nikandra just said, I have asked, why haven't they rolled out the ability to place orders after my clinic visit? Now it makes sense. We need to do it safely, so maybe that's coming. The next speaker is Dr. Linwei Wang. She is the Bruce B. Bates Professor of Computing and Information Sciences at the Rochester Institute of Technology. She's also director of the Personalized Healthcare Technology Research Center. I've known Dr. Wang for a long time. We've collaborated on research. The idea that we have a national, international reputation institution like RIT here in our city is wonderful. And Dr. Wang particularly has been very involved in computers, artificial intelligence. Her PhD is from RIT. And very excited to have her give us a little more of the research side of what's been going on in AI in Rochester.
Thanks for the introduction, Liu, and good evening, everyone. Very happy to be here. So as Liu mentioned, my task was to talk a little bit more about the type of AI research that's going on in the healthcare area in Rochester. And this is a very tall task, just given the sheer volume of research that's going on. So when I was thinking about this, I thought that I would just, I thought about my sort of personal experience as a patient and my encounter with the healthcare system. I don't feel well, I go to doctor to figure out what it is, and have it treated and follow up with the doctor to see how's it going, and hopefully I get back to my everyday life and the cycle starts again. So I thought I would just use this as an anchor and go from this sort of perspective to talk a little bit about the type of research project going on that sort of tries to use AI to support each stage of the cycle. Just a disclaimer before I start, the projects that you will see later are led by various colleagues and friends in the Rochester area, so I was only involved in a small number of them. And also the research project you will see are at very different stage of development. So some of them are already published in high impact venues, when some of them are really at its infancy. So some of them may sound a little bit more science fiction-like. So okay, let's get started. So let's say we don't feel well and we go to an emergency room. So what type of support AI can do? So as I think Greg already mentioned a little bit, in a very hustling environment in emergency room, AI, one of the most things it can do is really try to identify the patient that's at high risk and try to route them to the right test fast. But even for those who are waiting, their research are also being done to use AI to do regular symptom tracking so we can change priority and to help patients navigate the environments and also even predict how long you're going to wait. So as one example, let's imagine that a person had chest pain and called 911 or showed up in an emergency room. Sorry. And typically in that time, an electrocardiogram, or EKG, is taken, and from there, doctor will try to confirm if there's a heart attack. So we are getting really good at detecting major heart attack from this type of signals. But for minor heart attacks, where it's really the artery is occluded partially or completely, so it's important, but it's still very hard to detect with human eyes right now on these signals, and it requires additional testing. And oftentimes actually, it means hospitalization with prolonged observations. So for some patients, this delay can mean that the best time to intervene has been missed. So a group of clinicians led by Dr. Al-Zaidi at UFR is actually working on developing an AI system that can take an EKG, and this can be collected even before the patients get to the hospital, en route to the hospital, and use that to improve the detection of minor heart attacks on these signals. And their recent publications show that with that, they can actually detect 37% more minor heart attacks that would have been missed. And this is example really with AI system that can be used to really save time when every minute matters. Okay, so now we go see a doctor, and the doctor needs to help us find out what it is and how severe it is. And this is an area where there's a significant amount of research that's going on in AI, because as I think Dwight mentioned earlier, AI is really good at combining different types of data, imaging data, pictures, lab test results, and even just clinician notes, and use that to help clinicians to confirm their diagnosis, or sometimes even to help predict risk for complications. So as example here, let's look at dermatology as example. So skin cancers like melanoma, it can be very deadly if it's detected late. And due to shortage of providers that was mentioned earlier as well, that many patients nowadays have to wait for a very long time before they can even see a dermatologist. One of my colleagues at the RIT, Dr. Tao, is leading a project that's trying to improve this, and the vision they have is basically a chatbot like ChatGPT, but it's really good at talking to the patient about this type of disease. So just imagine in the future that a patient can take a picture of the skin lesion and just upload it to the cloud, and this agent will be able to have a conversation with the patient to sort of explain what they are seeing in the images and answer questions, and even provide some summary of their discussion for the clinicians. And this is basically an example where AI can be used to support early diagnosis of disease, help address shortage of providers, and this can be done really regardless of the location and backgrounds of the patients. All right, so we have some diagnosis, and the clinicians need to figure out how to best treat us, whether it's some procedures or whether it's medication. And this is an area a lot of research is going on to use AI to help determine basically what is the best intervention moving forward, whether what's the optimum dosage of medication, or what is the best way to target in a procedure or in a surgery, and before, all done before it's tested on the actual patient. And in many cases, AI can also be used to provide support during the procedure. So as one example, we can think about a surgery that's performed inside the skull base. So this will be a setting where the surgeon have to navigate really narrow spaces that involves a lot of critical anatomy. So in current practice, as you can see in the middle figure here, the clinician use imaging guided system. So what it means that there's scans of the skull that's taken before the procedure, and the critical anatomies are all identified in those. So during the procedure, the clinician can use this to see where is their surgical instrument against this critical anatomy that helps them navigate. The problem is, as the procedure proceeds, tissues are being removed and anatomy drifts. But this picture doesn't change. So that means as the procedure moves on, there is a bigger and bigger difference between what the clinician can see on this image and what is really going on in front of their eyes. So over time, they have to start to rely more and more on their own memory and experience. So again, creating additional challenges for surgeons. So one of my colleagues, again, Dr. Yang at RIT, collaborating with clinicians at UPR, are working to change this, to improve this. So their goal is to basically change this static imaging guidance to something that's dynamic, utilizing the endoscopic data that they are already collecting during their surgery. So as you can see on the right panel of this figure, the idea is basically with this, the doctor can then see in real time what has been removed, what remains, and what is changing, and what is most at risk. So this type of guidance during the procedure can really reduce the cognitive load on the surgeon so that they can focus on what they really need to do. All right, so we are treated or diagnosed, and we are sent home to recover and follow up with clinicians. So what can be done? So in this case, there's, AI can be done to do simpler things, for instance, summarize the visit and plan for the next steps. But they can also be used to doing, more challenging tasks, for instance, to see how we are responding to the treatment and whether things need to be treated or whether things are going well. So again, as example, let's come back to heart diseases. So ventricular assist device is a very important therapy for advanced heart failure patients as sort of bridge to when they are waiting for transplant, or sometimes just as a destination therapy itself. The diagnostic of ventricular assist device patients, however, requires highly trained medical professionals, and oftentimes it requires invasive procedure to assess what's the state of health for the patient. So a group of faculty at RIT, led by Dr. Colosy, and also, again, in collaboration with a group of clinicians at U of R, is working on this thing that they call it smart stethoscope. So the idea is that this device will use the native heart sounds as well as the motor wiring of the device to assess not only the sort of dysfunction of the device itself, but also the underlying health state of the patient. Because oftentimes this underlying state of the patient is the main reason that the device is not working to start with. And with this, again, this is something that you can have at home. And this can alert the patient as well as the providers that something's not going well and something has to be changed. All right, so now we come to the last part, which is also the part that I'm most excited about in terms of what's the potential of AI. And I think as already alluded by the previous speakers, we spend a lot of time outside hospitals, not seen by the clinicians, therefore they don't have any data about us in that period of time. And with all these wearable data, mobile data, home devices that are nowadays available in our homes, and our increasingly more and more regular possibility of regular imaging and checkup with clinicians and with electronic health record, AI can really harvest this data and use that to monitor our well-being and detect when things are changing in a wrong direction before any symptoms hits us. And in many conditions, not only we can detect this, but AI can help deliver interventions, for instance, to the mobile devices of we all have, to help us, for instance, change our lifestyle or change our medication adherence to help change the trajectory towards a better direction. And ultimately, the hope is that then we will have a really more personalized way to go see clinicians at a schedule that's more appropriate for our risks. So this can really be done across the lifespan, and that's where I want to spend a little bit more time and just talk about 3 projects that really shows how this can be done across lifespan. So I have been working with a group of clinicians, including Li Wei here, on a project where we're using this concept on monitoring heart failure patients at home after they are discharged from the hospital. So the idea is basically by monitoring the physiological signals that we can collect at home every day for these patients, together with some questionnaire they can answer on their mobile devices, we can detect the worsening of these patients before they hit the emergency room or hospital again. And we are sort of extending the same concept to help monitor the mental well-beings of individuals and even their craving for substances. Again, use different type of wearable data and home devices and mobile data. And again, with the same idea to detect a decompensation or to detect something is heading towards the wrong direction before it gets really bad. And in this case, the nice thing is that in this case, when something's detected, you actually can trigger some sort of just-in-time interventions, again, for instance, to the patient's, to the client's devices. One of my collaborators at U of R, Caroline Easton, they have an app that has have an avatar in it that basically talks to the patient and guide them through the behavioral health therapy. So this type of thing, basically, you don't have to, when decomposition is detected, you don't have to head to the doctor's office. Interventions can be delivered to you on your mobile app when you most need it. And all of these preventative measures can be done even before we were born. So fetal weight estimate is very important in informing a lot of decision makings in pregnancy in terms of, for instance, determining the best timing and mode of delivery, but also just in monitoring the health of the fetus. Right now in current practice, the error of fetus weight estimation is about over a pound, and that can change a lot of clinical decisions. So I was fortunate to be a mentor of this very bright young scientist, Dr. Dresbach at U of R, that she has been actually working on developing an AI model that can use the regular ultrasound images we will already get in pregnancy and use that to more accurately predict what the birth weight will be for a fetus, and use that to better inform decision making. So I hope with these examples, I've sort of give you some examples of how AI can really help us, help the whole medicine practice to shift towards more preventative basis by basically helping us to find problems earlier and to keep us on track day to day instead of waiting for the symptom to hit us before we go to see the doctor. And with this, I would just want to thank you all the principal investigators who are leading the research project I just talked to you about, and thank them for taking the time to provide their content for me for this talk. And of course, ChatGPT also helped me quite a bit for generating the slides. So with that, I will pass the floor back to Li Wei.
Thank you, Dr. Wang. That's, great things happening in our community, which is amazing. So you've kind of been taken through a little bit of everything about AI, and now a very important conversation with Dr. John Harrington. I don't know if any of you have thought about Skynet and HAL and a few other things, but the ethics of what we do are very important, and I'm very pleased that Dr. Harrington is speaking. Assistant Professor of Health, Humanities, and Bioethics at the University of Rochester, did his education in Queensland and got his PhD at the Australian National University. So been on the other side of the world, but we're very pleased that he is going to come and speak about ethics and artificial intelligence in healthcare.
Okay, g'day everyone. I'm going to try and give this talk very quickly so we can get to a little bit of a discussion, because I think some of these ethical issues are best sort of fleshed out in a discussion and a conversation. So, we've done all of that. So, we've seen a bunch of different ways in which AI can help clinicians and really improve their workflows, improve diagnosis, improve risk stratification, potentially improve the administrative back end, etc. And I think it would be right to say that we're sort of in the patent medicine phase of AI. So just like drugs in the late 19th century and early 20th century, there are dozens and dozens and dozens of new widgets being produced every day, and there is scant regulation and very little understanding of the sort of governance, the appropriate governance structures for these. And so I think a lot of people are tempted to say what we should do. And so I think what that's done is generate a lot of fear and anxiety amongst patients, amongst community members, and I think also amongst clinicians about what AI is going to do to their jobs, how is it going to change the practice of medicine, what can we do to make sure that it is safe, efficacious, used voluntarily and consensually, and is oriented towards improving health justice. And so what I'm going to talk about here is some of the ways in which we might ask ourselves, or what some of the complications that might arise when we try and apply the traditional bioethical framework of non-maleficence and beneficence, autonomy and justice into the context of assessing artificial intelligence tools. And I'm going to do it by talking about 3 little cases very quickly. So you might have come across this study. It's from last year, in fact, almost 2 years ago now. Google released a version of their Gemini chatbot that was tuned towards answering medical questions. That was MedPalm 2. They now have another model called MedGemini that's a sort of supposed to be an advance about this. And, there was lots of headlines where people said, where the result was, well, it has this 86.5% accuracy on the USMLE, right? An average human clinician gets an 86.5% on the USMLE, right? MedGemini can get 91%, right? So it's outperforming clinicians on a board exam, right? And in fact, its answers in diagnostic conversations with patients were rated as more empathetic. So it was not only more accurate at answering diagnostic questions, but it was also rated as more empathetic when it did so, and more informative, in fact, was the other thing. So one question we have to ask ourselves, right, as ethicists who are interested in improving care, benefiting patients, is this efficacious care? And what would make it efficacious care? And I think there are 2 worries that come up when we think about evaluating the efficacy of these models. The first is a worry about the robustness of the model. So these artificial intelligence entities are fundamentally, you should think of them like parrots, right? They are very good at spitting out a form of words that sounds like what would be the right form of words, right? They're very good at mimicking what a doctor would say in certain contexts. That's how they're structured. But they don't have, as far as we know, fundamental mechanistic understanding of how the medicine works. So they don't have an understanding of acid-base physiology, like they don't have an understanding of the chemistry of drug interactions. What they're doing is seeing doctors in the past have not prescribed these 2 drugs together, and so I'm not going to suggest that either, right? And so we worry about what they do in these sort of like edge cases where we're just outside, we're in rare disease cases, or we're in medical contexts where the patient has a very particular or specific confluence of symptoms or diagnoses. And there the worry is parrots aren't good enough, right? Because there won't be enough background information or enough information in the training data to give the right answer. What you need there is a mechanistic understanding. You need to be able to put together all the different pieces of knowledge that you learned in medical school in order to get the right answer. And so there's one worry about that, robustness. And I think the hope is that these models will improve over time, right? That they will solve some of those mechanistic problems, that agentic versions of these models will integrate together to improve robustness. But I think one of the other things that one of the other questions that these things raise is, suppose we solve that accuracy problem. I think there's a real question about what these entities are going to do to clinical practice, and what exactly is the role of a clinician in a context where these models can answer questions more accurately and do so more empathetically and potentially more informatively than a human clinician. why is the human there, right? And I think, what is it about clinical practice that's distinctively human? Is a question that we need to ask ourselves if we want to know whether or not integrating these things into clinical practice is actually improving care. Okay, a second case. What makes something consensual or voluntary in this case? So we actually heard a lot about ambient documentation systems. These are the things where when you're in the clinic, the DAX system that Dr. McAndrew talked about, where it'll automatically take a note, right? But that is just the tip of an iceberg of a very large number of what's called ambient intelligence systems. These are persistent systems that sit in the wards, recording, or in surgical theatres, recording video, audio, infrared information, all sorts of, they have depth sensors sometimes. They record all sorts of information, and the goal is to integrate that information so that you can answer really complex health resource questions, right? So how many staff are needed to ambulate frail patients? Do you only need one, or do you need two? Well, an ambient intelligence system can help you answer that question by continuously monitoring what happens in the wards, right? It can look at good clinical practice adherence in surgical operations. So there's now lots of attempts to integrate ambient intelligence systems into clinical review processes, right? And it can be used to sort of do scheduling, right? How many staff do you need on a ward? Well, you can maybe reduce the number of staff that you have on a ward if you have an ambient intelligence system that is able to monitor individual patients in each of their rooms continuously. Right? And one question you might have is, how voluntary are the use of these systems, right? Because these systems are either on or they're off for everybody in a ward. It's not like DAX, where hopefully the clinician has asked you whether or not you consent to the use of DAX in the clinic visit and you're in a private room, right? Instead, the wards are continuously monitoring everyone in them, including patients, clinicians, custodial staff, family members, administrators who maybe get lost and wander into a ward sometimes, right? Everyone's being monitored all the time, right? And so there's a real question about how you opt out of those kinds of systems in the way that we normally think you have a right to opt out of clinical interventions, right? Well, the opt-out option here is exiting the hospital. It's finding somewhere else that doesn't use an ambient intelligence system, and that's increasingly going to be very difficult because almost every hospital system will use them, right? And so we have to have a discussion about whether or not the use of these systems is compatible with the autonomy of individual patients, the privacy of third parties like family members, and really what kinds of ways in which this redistributes power and control within a hospital system, right? It gives an enormous amount of power away from clinical workers and gives it back to administrators. Lastly, are these things fair, right? Are they just? And there are lots of examples of AI bias that I think many of you will probably be familiar with. The healthcare world is full of examples of failures to control bias appropriately in healthcare AI systems. And there's been a lot of work done to try and remediate that. Like, I don't want to undersell that, but it's been a main focus of the research and clinical community. Here's an example the risk stratification algorithm. It's a very famous example from Nature, from Science in 2018, Obermeyer et al. The basic idea was an insurer is trying to predict who had the highest health needs, so they can roll those people into a prevention program. High-risk individuals are invited to a screening meeting and then an enhanced primary prevention program, a dedicated monthly office visit. It turns out when they looked at the subpopulation performance of this system, Black patients were more likely to be enrolled into the prevention program overall, but they were less likely to be enrolled compared to an equally sick white counterpart, right? So the idea is if you kind of rate the chronic disease burden of each individual, and here they used a thing called the Charlson Comorbidity Score, which is a way of rating the number of chronic conditions people have. Folks who have 2 chronic conditions, right? If you're Black, you get a lower risk score than if you're white, right? And the question was, is this fair, right? Is this a fair way of doing things? And it turns out that it's actually a really difficult question to answer, because there are multiple metrics of what counts as fairness, right? And you might know this from your days in the schoolyard or when you're trying to figure out how to split a bill at a restaurant, right? There are multiple ways of thinking about fairness, right? Should everyone pay for what they ate, or should we just split the bill equally, right? Should it be based on who has the highest salary this week, right? All these ways are different ways of splitting a bill. The same problem occurs for healthcare algorithms, right? And there's a number of sort of famous pieces of research that show that it's actually impossible to satisfy all the different metrics of fairness simultaneously. And you get sort of weird things like this, where on one measure of fairness, it looks pretty good, right? That's the purple one. It looks like the performance is roughly equal between racial groups. And then if you use another measure of fairness, it's very unequal, okay? And so what's important here, I think, is that we face some real challenges trying to implement standard clinical ethics into the assessment of these AI models. And there's 3 things that I think I just want to leave us with. The first is clinical ethics is focused on optimizing harm and benefit, or optimizing the ethicality of an interaction for one patient at a time, right? That's the way that it's modeled, right? Rather than fairly distributing risks and benefits between patients, which is how you have to think about AI, because AI are applied to whole populations, not one individual patient at a time, okay? The second is that there's really big value disagreement, right? We're applying this to whole populations, so we apply the ambient intelligence system in the ward, or we apply the triage system at the door, right? And people disagree. People disagree, sometimes really vehemently with one another, about the value of a particular way of dealing with risk, right? Some people want more intervention, others want less intervention. But with an AI, you have to pick one balance between more or less intervention for everybody, okay? And that's a problem. Lastly, I think that AI involves a pipeline of decisions, all the way from the collection of the training data, right, at the very beginning, and the training and design of the system, through its deployment, the training of clinical workers to use it, and then post-review and evaluation, right? And that's very different from the way that we think about clinical ethics problems at the moment, which is that we think about them as a single clinical interaction, right? Or a single hospital stay, where we get to very tightly focus on what's in front of us, and we are supposed to, in fact, really forget about a lot of the things that have gone on before and after. And with AI, you can't really do that. Okay, so I'm going to leave us there. Thank you very much for working through those questions with me. I'm looking forward